So what's up everyone, I am Shams and today I have got the opportunity to talk to Dr. Shreeraj Talwadekar, Assistant Professor of Microbiology at Seth Gordhandas Sunderdas Medical College, Mumbai. After talking to him, I realized that he is very humble, very intelligent, very passionate and is very much dedicated towards his work, and this has inspired me a lot. He believes that a doctor should also have a life outside the hospital, and with this mindset, he started putting content on social media and now runs a YouTube channel which goes by the name The Travel and the Food Doctor. So I would like to thank Dr. Shreeraj Talwadekar for having this conversation, and I would like you to listen to this podcast, and I believe that you will enjoy as much as I did. So here is my conversation with Dr. Shreeraj Talwadekar.
First time it was just reduced.
Yes,
So
sir.
first time it was just reduced, and again within few months, again I kind of hurt myself and got a fracture. That time there was a what you say internal fixation done. I still have those,
Okay, there is a remark
kind of.
there.
Yes, yeah.
Yeah.
So that time when I was admitted, I
Mm-hmm.
used to see. I was admitted in the general ward, and I saw some patients, different patients. And that time I had a dream that I should be an orthopedic doctor,
Okay.
and that's how that's how it started. And once again in the eighth standard, I kind of got the radioulnar fracture once again on the same
So
side.
sorry for. Okay.
That's all right. It kind of inspired me actually to be a doctor. I always liked science,
Okay.
especially biology.
Biology, right?
Yeah, yeah.
So have you ever thought of becoming scientist?
Yeah.
I'm.
So the
Yes, sir.
thing was, actually, I was more inclined towards being a scientist, and as such,
Okay.
now my post graduation is in a field which is almost a basic science.
Hmm.
Apart from being into services of seeing the patient samples, but a lot of things we do is includes the basic sciences, that is
Okay.
microbiology. So in a way, I'm a scientist itself right now.
Yes, sir. Sir, you did your MD in microbiology, right?
Yeah, yeah,
So, sir, according to a broad definition, if we talk about the broad definition of microbiologist, then microbiologist is a person who studies microscopic organisms like bacteria, parasites, fungi, and the
yes,
interaction between them. So, sir, can you please
yes,
elaborate the role of a microbiologist, or in other words, can you please elaborate what you do as a microbiologist on a daily basis?
yes, yes, certainly. So I'm more of a clinical microbiologist, what
Okay.
we call as clinical microbiology. What generally the layman understands as microbiology is the technical microbiologist. Like whenever one says pathologist, they assume that he's a MBBS and then he has done pathology as
Mm-hmm.
a post graduation. But when we call as microbiologists, most of them don't think that this person has completed MBBS. They think that it is MSc microbiologist or
Oh,
something like
yeah.
that. But certainly, we are clinical microbiologists. What we basically do is it is the approach towards lab diagnosis of the infectious diseases per se. It is almost a subset of pathology. Previously, it was
Okay.
both were combined. It was called as pathology and bacteriology. And
Mm-hmm.
some 20, 30 years or more earlier, it kind of got bifurcated into pathology and microbiology. So
Okay.
mainly, as you know, nowadays you have got this zoonotic diseases, you have
Mm-hmm.
emerging diseases like COVID-19 and
Exactly.
re-emerging diseases which were there in the past like Ebola, Marburg, etc.
Yes.
They are coming back because mainly
Mm.
because of their viral diseases and antibiotics do not work on them.
Exactly.
Previously, people used to die because of typhoid, cholera. Now we see that there are not much deaths due to such diseases. So nature is trying to balance it out, and somewhere or the other, because of the rising population, you can see that viral diseases are coming up because
Mm.
of close proximity to nature. We are getting so many zoonotic diseases from the wild or the domesticated animals. and also the rising antibiotic resistance, or what is known as antimicrobial resistance. So
Mm-hmm.
certainly clinical microbiologists are playing a very important part in how to diagnose a particular infection, especially when it is not being diagnosed by the routine test. You know, if you get a fever and you do a malaria test and it comes positive, then you take a anti-malarial and that's the end of the story. But
Mm.
sometimes you get some kind of atypical infections in which all your tests will be kind of negative, what we call as pyrexia of unknown origin. In that,
Okay.
you will investigate the patient and still you don't know what is the exact cause. So the inputs of a microbiologist in this case, a clinical microbiologist in this case, is very important. What other test besides what you have routinely done, like a CBC, a malarial test, a malarial antigen, or a peripheral smear you have done Vidal, but
Mm-hmm.
you have not got any clues. So can you go for some another culture like a blood culture or a bone marrow aspirate or any kind of a urinary antigen test, or any kind of a PCR? If there is
Mm-hmm.
any localized collection of pus, can you culture it and see which bacteria it is? Can it be something known as a non-tuberculous mycobacterium, which may not respond to your routine antibiotics? Can it be something like a mycoplasma or a chlamydia, which will not respond to your routine antibiotics? So it's kind of a specialization mainly into how to go about in an infectious disease mainly. Our domain is completely into the infectious disease, and whenever the
Mm-hmm.
physician is stuck at what to do next, then that is where a lot of input comes from the microbiologist, whether the patient requires an antifungal or not.
Okay.
And there is another subset in which recently it has gained much of importance, where microbiologists play a major role. It is hospital infection
Hmm.
control, or let's say healthcare associated
Associated infections.
infection control. Yeah, more
Yeah.
than hospital, we should call it healthcare associated
Hmm.
infection. And to control them, generally we have a hospital infection control committee,
Yeah.
which is
HICC.
most of the times spearheaded by the microbiologist. So that is
Exactly.
going to be a very important thing. COVID actually showed us the importance of how important infection control is. The first principle of ours is, like Florence Nightingale had said, do no harm. First, do no harm. The patient is coming to us with what you say, desire to get
Hmm.
treated. We should not give the patient a new
New
infection.
infection.
Even if
Exactly.
the patient doesn't get cured, that is also in a sense okay, but we should not give the patient a new infection of sorts. So that is why hospital infection control is very important. And if you have heard about NABH, that is National Accreditation Board for Hospitals, it is now a mandate that you should have all the surveillance audits like hand hygiene, your biomedical waste disposal, and
Hmm.
your device associated infections like
Needle stick
catheters,
injuries there are also.
stick injury,
Yeah.
surveillance, all that is going to, it's coming up in a big way. Awareness is increasing, and the focus is now more on that. So microbiology is certainly an upcoming field, and certainly gained importance in the last 2 years or so because of
Okay.
COVID-19.
COVID-19. Exactly. So, sir, hospital associated infection is a, you know, very much crucial part of healthcare system.
Yes,
We
certainly.
actually don't give that much credit to healthcare associated infections, and when we look at our daily life here and there.
Yeah, yeah. That is partly because the community, when we call it as community, that is outside the
Mm-hmm.
healthcare institutes, they are not aware that much about antibiotic resistance and
Exactly.
all that, how the infection might spread due to the hands of the healthcare workers, etc.
Mm.
And when we step into the healthcare institutes or the clinical area per se, especially the ICUs, where we find all these multi-drug resistant
Mm.
organisms, which are very difficult to cure. They increase the length of stay of the patient. It puts a economical burden on the not just
Exactly.
the patient but the country as such and the
Mm.
community as such. And some of them even result into fatalities. So this is
Exactly.
a very
Okay.
important problem, which some of the clinicians don't take it that seriously. They feel that if we give antibiotics, the patient will be cured of the infection, but it's not so easy. It is very difficult, and the patient is already in a compromised situation in the ICUs.
Mm.
The kidneys are compromised. So
Yeah.
many of the higher
Immunity is
antibiotics,
compromised there also.
yes, so
Hmm.
many of the higher antibiotics we give, they further deteriorate the serum creatinine and kidney function, etc., etc. So prevention is always better than cure. This
Yeah.
is the old dogma we have
Hmm.
been hearing so often, but somehow we don't take it that seriously. So
Exactly.
much so that pre-COVID, they used to tell us, like physicians, whenever microbiology used to keep a session on hand hygiene, they used to say कि भाई हम ये पेशेंट ठीक करते बैठे कि हाथ धोने का कैसे सीखते बैठे. So
Yeah.
that is the attitude. But after COVID, we have seen that now people are even washing their tomato and potato with soap water.
Exactly.
So the fear of COVID
Hmm.
has taught people more than probably what we should have. Microbiologists and infection control specialists should have.
Very nice. Sir, you have mentioned the word antimicrobial resistance, and we have heard in the news also that there are many microorganisms, basically or particularly bacteria, which have got or developed so much antibiotic resistant that humans have shortage of antibiotics against new emerging bacteria. So I want to know from your perspective how close we are for a bacteria which is resistant from all the antibiotics. I mean, how dangerous this condition could be in the near future.
Yes, yes, certainly we are many people say that antimicrobial resistance is a ticking time bomb. I would say
Okay.
that it has already exploded. It is not even a ticking time bomb, it has already exploded. Many of the patients which died due to COVID
Mm-hmm.
in the ICUs, if you see the real cause of that, it was the MDRO infections which causes sepsis or ventilator associated pneumonia in the ICU rather than COVID itself. Yes, COVID did cause pneumonia and respiratory failure, but some of the patients which managed to survive that failure, respiratory failure,
Mm-hmm.
did succumb to the multi-drug resistant organism, bloodstream infections, or a pneumonia due to ventilator
Ventilator.
associated pneumonia, etc. So this is a huge thing. We are almost back into the pre-antibiotic era. When I started residency, a drug known as colistin used to be quite
Mm-hmm.
pretty susceptible. We used to get nice inhibition of the bacteria. We see the zones around the antibiotic, and we used to get nice zones around the antibiotic. And now we are just, I must have finished residency some 8 years or so back,
Mm-hmm.
and now it has started to give resistance. We see colistin resistant Klebsiella pneumoniae, we
Okay.
see colistin resistant Pseudomonas. Then we see on the gram-positive spectrum, we see vancomycin resistant Staph aureus, we see vancomycin resistant Enterococcus. These are higher drugs which should be reserved per se, but now even they are failing because we are giving them left, right, and center. In if you talk about Mumbai city itself for tuberculosis, fluoroquinolone resistance is almost always guaranteed there because most of our family physicians or base primary healthcare physicians
Mm-hmm.
kind of give fluoroquinolones like moxifloxacin, levofloxacin for normal cough and cold, which may
Okay.
mostly be a viral etiology. So it is going to be a big thing. If you see last 30, 40 years, no new antibiotics per se have come except for something like a bedaquiline or a linezolid.
Okay.
That is a new group of antibiotics have not come. We have just modified the old antibiotics like ciprofloxacin.
Mm-hmm.
We make it the levo form, and it becomes levofloxacin. Then we modify it further, it becomes moxifloxacin, the various cephalosporins. So we are just changing the some structures of the antibiotics, but we are not getting a very new group of antibiotic per se, except for bedaquiline, which has come for TB, and linezolid some 30 years or so. And if you look at it from a pharmaceutical point of view, they also don't invest much in R&D for a new antibiotic because they know
Okay.
bacteria are smart, that if you spend crores on producing a new molecule for a antimicrobial, in 3 4 years the bacteria is going to override that molecule, and then all
Okay.
the research is going to go waste. They are not going to recover the cost of the research. So prevention, as I said, is going to be the key. You have to take 100% or more efforts so that person does not develop a healthcare associated infection. There
Mm-hmm.
is no institute or no hospital in this world which has a 0% rate of healthcare associated infection.
Yeah.
But Having said that, our effort should be that as much as possible, we keep that rate as close to zero
Good.
as possible. Whenever you do the best of practices, still there might be some infections which is not in your hand, but at least you tried your best.
Yeah,
So
we
the
should try.
best practices must be followed. Every patient deserves a good line of care so as to they don't get an infection from the healthcare workers.
Okay, nice, sir. Sir, I read about you and found that you were invited for COVID RT-PCR lab during COVID-19, and you
Yes, yes.
immediately or deliberately accepted the offer, even though you had 10-month-old child, which I must say is very inspiring from your side.
Yeah.
So,
So basically, I generally don't say no whenever something new comes. I take it
okay.
as a challenge. And as you all know, it was the nation's need.
Hmm.
COVID-19 came in globally somewhere in December 2019 in China. And the first case was detected in Kerala. First case in India was
Yeah.
detected in Kerala somewhere around March
Okay. Hmm.
2020. So my kid was born in April 2019. He
Okay.
was not even a 1 year old. His birthday was in 15th April 2020. So he must be some 11 months
10
old.
months. Yeah.
We had got instructions from the higher authorities that we need to start a COVID-19 testing. That time only Kasturba was testing in Mumbai for
Okay.
COVID-19 RT-PCR. So we had got instructions, and the then head had asked me that would you like to work for this lab? And I'd had very minimal experience in molecular. I had worked in a private lab before for
Hmm.
molecular diagnosis. Uh, but the main was the fear because most of the staff was not ready to work. No one knew at that time what exactly is COVID, how it spreads,
Exactly.
what kind of danger it possesses. Because in India, the cases had not started except for one or two in three cases in Kerala. So
Hmm.
I thought for some 5 seconds and then I said yes. To be very honest, I thought it might not last as much as it did. So I thought
Yeah.
maybe chalo ek do mahina karna padega because that time even IPL would happen or not and all that discussion was going on. So we were like, ठीक है ये आएगा थोड़ा दिन बंद रहेगा. That
Yeah.
time even lockdown was not announced. So
Yes.
I said it might go and I will do it for a month or so. So I was given a very nice accommodation in the campus itself, and I was doing
Okay.
night duty. I did it continuously for 9 months, almost without a break. There was a time when we actually had no weekly offs. We were
Okay.
working 7 days a
Days
week,
a week.
including the technical staff. So hats off to them. They do the most of the work. The technical staff did most of the work. We used to interpret the results. We used to convey it to the physicians. We used to convey any positive to the authorities, that is the BMC in this case. And then they used to trace the contact. So it played a huge role in, kind of containing or not so that the pandemic does not spread. Because
Hmm.
once you get a positive, they used to trace him or her, and then kind of isolate that patient so that other people do not get affected. So it was a huge role. People think that labs do not play an important role, but yes, if you can contribute very significantly to
Hmm.
the society, even if you are in a paraclinical branch, even the
Exactly.
preclinical branches in our college, they
Mm-hmm.
contributed a lot. They were managing the logistics, like even the first year subjects, even second year subjects, they were managing the logistics, providing PPE kits to the healthcare workers, managing the stock of medicines, etc. So it's a team effort, and at that time the country really needed it. So I never thought that I should say no. It's like
Yeah.
when you have a war, the soldier cannot say कि मुझे गोली लगेगी तो मैं नहीं कर सकता
That's
हूँ, मेरा
so
बच्चा है.
inspiring, sir.
It was kind of a similar, yeah. But yes, to be very honest, I thought that it would end much earlier than
Hmm.
it actually did. Just kept on, the cases just kept on increasing.
Rising, rising.
I did night duty for 9 months at a
Yeah.
stretch.
So,
Yeah.
sir, what was your personal experience from this COVID incident, from your growth side, from learning side, like this?
Yeah, so it really changed me as a person.
Okay.
because first of all we were doing night duty, so me and just two of the technical team
Mm-hmm.
used to be there. That was
Okay.
the whole world for me for almost 2 3 months.
Mm-hmm.
We used to hardly see any people because there was a lockdown. I have never seen KEM hospital so barren, or I've never seen Mumbai streets so barren, not a soul in sight. And I used to start, our shift used to start somewhere around 9 p.m. and it used to end at around 8 a.m. or so. So almost 11 to 12 hours. We used to work in the night. All the samples used to be processed and then reporting used to be done. And there was only a technical team with me. I was the only kind of faculty at that time, and we had some resident doctors along. So that was our only world. We did not see people around. The whole time we used to just report and then enter and do the ICMR entries and stuff. But we used to have a lot of fun in the breaks and all. We used to have some kind of food together. We used to cook something, and it really changes you as a person.
Okay.
Trust me,
Mm-hmm.
I'm very sympathetic with people who have mental issues. There was a time when I did not kind of feel any kind of emotions. I did not used to smile. I did not used to cry either. I just used to feel nothing. That
Okay.
and especially because my child's birthday had come near, and I was not sure whether I would be allowed to kind
Meet
of
him or not.
go home to
Mm.
celebrate his birthday, first year birthday. And that time I had become really emotional, but I had very nice technical staff who supported me a lot in this journey, and it really told me that what are we doing in our life, thinking about small little problems, but there is so much to life. I had actually gone for some work towards the casualty medical officer at
Okay.
that time, and I literally saw a lady begging that her husband's life be saved. He was a young kind of person, and both the lungs were filled with fluid and
Mm-hmm.
respiratory failure, and she was literally crying for a 40-year-old man to succumb like this. Patient had almost died, and there is nothing that the doctors can do at this stage. But she was begging like, "Oxygen chadwa tumi kai pan kara, but save the life of my husband." And it really shook me to the core, like what how unpredictable life really is.
Exactly.
So once that night duties ended, I really started looking at life in a different perspective together. And I thought that we should do something other than our hospital work. Most of us doctors, they are just talking about medical field day in and day out. Even if we
Mm.
meet as friends, this is the only thing we talk about. Like, you
Okay.
are students, you guys keep on talking
Yeah.
only about studies.
Studies.
Even
Studies.
if you're going on trip, that अरे
Mm.
pharma कैसा है, micro
Exactly,
ऐसा
sir. I
है,
can completely relate.
ASM ऐसे है. That is not life. So I thought that I need to do something other than medical or
Medical.
what is concerning healthcare. So I had a YouTube channel. I just
Yeah.
restarted it with
Okay.
more kind of passion and started making travel videos
So that is actually my
for this.
next questions.
Yeah.
I read about you and you said that you had some realizations during COVID time that made you started
Yes.
putting content on the social media like YouTube and Instagram. So I was curious, what were those realizations?
Yes, yes. So that's basically is that our life is very unpredictable, and it seems cliched, but it is true that money is not everything. Yes, money
Okay.
should be there. Surely you should be ambitious. Surely you should think about earning more, but it is
Mhm.
not the only thing. If you are going to earn and not use it, so what is the use? And
Exactly, sir.
I always had a passion for storytelling. So when I came back out of the night duty, at that time during the lockdown, many people had started YouTubing. There was not
Yeah.
much competition pre-COVID, but during COVID, people were at home and they had started YouTubing a lot. They had started using social media a lot, and I just thought, ki, why not we also do? We have some kind of passion for travel. I like food and travel, so why not I do something of my own? And that
Okay.
is how I first we started a recipe channel for my
Mhm.
as a family. It's a Marathi recipe channel, and then I thought, yeah, I should restart my travel
Your own.
channel. It was never a travel channel per se. It was just a channel, YouTube channel named after me, my own name, and I used to just randomly put any kind of videos out there. But then I re-christened it into a the travel and food doctor, and I started making proper travel videos using some of the old footage I had. And after that, anywhere I'm going now, I just shoot stuff and then I edit it and put it as a proper video. I try to give information to the audience about that
Hmm.
place, some any kind of historical significance, or how to reach there, what might be the cost, etc., etc. So
Yeah.
that's how the journey started, and now I'm at about 1,500 subscribers.
Yeah.
So
I was
I
actually
never
watching your
expected that.
channel and the videos were actually good.
Yeah,
Your vlogs were, informative
yeah,
type very
yeah.
much.
Yeah, so I never expected that. There was a time when I used to see have some 100 subscribers, and I used to think, "Arey wow, 400 honge." Then when it became 400, "Arey wow, kabhi 1,000 subscribers honge." And now I'm sitting at 1.5K. So it's a very nice experience. I never did it for kind of getting a
Yeah.
monetary benefit from that. It just keeps me engaged. It just gives me
Other
a
than the
good
medical
kind of
field.
vibe. Yes, yes, very much. I spend my Sundays sometimes editing videos and
Okay.
obviously with family as well. So it's a very good stress buster to not think
Yeah.
about what is happening in the hospital, not think about what is happening with the patients. You have to somewhere detach. Yes, we will always do the best for our patient, but that doesn't mean we should 24 hours be
Think
immersed
about it. Yeah.
into that kind of atmosphere.
Environment. Yeah, exactly. You did all your work by yourself, sir. Like editing
Yes,
all
yes,
the
very
stuff.
much. I edit my own videos. I do my own
Okay.
thumbnails. I do everything by myself. I always used to like it, like doing all this stuff, editing videos and all. I always, even during college days, I used to do a lot, and
Nice.
everything I just learned by myself. I used to see other YouTube videos,
Mm-hmm.
what kind of things they do, how to increase the viewership and all that. There are
Yeah.
certain small, and even I'm learning even today. It's not that I have many subscribers, so it's still a rookie channel, so to speak. But yes, I did get very good positive response from many
Yeah.
of the relatives and friends, and even neutral audience, neutral viewers are also
Mm-hmm.
complimenting. So I try to improve in each and every video. I try to make something new in the thumbnail. I try to add some uh, feature or a filter or some kind of effect in the video. I try to add more information. I do a bit of research about that place
Okay.
before uploading the video. So, kind of putting more into it. It does take a toll, but I enjoy it, so it doesn't feel that it's a burden.
Yeah.
That's the main thing.
If
If
you
you are
enjoy the
enjoying
work,
it,
you
then
don't
it
feel
will
the
not
work
be.
as work.
Yes, yes. And don't go and look that this person is doing videos on finance, so I should also do videos on finance. This person is doing video on NIT PG, so I should also do video on NIT. That is not how it works. If you are enjoying that particular topic, there will always be a niche audience for what you enjoy, and that is where you should do your videos. Otherwise, you are not going to enjoy it. I like making travel videos, therefore people like my videos. Otherwise, you cannot fake in
Hmm.
your videos. It
Exactly,
should
sir.
come from your heart that you know about the subject, you are passionate about that particular topic, then only people will like the content.
Exactly. I completely agree, sir. So, sir, you are doing all of this social media content just out of passion, right?
Yes, yes, very much.
That's great, sir. So, sir, let's talk about teaching.
Yeah.
I read that you use memes of microbiology to teach everything. And just sir, before starting out, let me just tell you that I love teaching. Teaching is one of my greatest passion, and I used to teach to my friends in my class and all these things. So, sir, how do you think about teaching, and how can you make
Yeah, so
subjects like microbiology interesting?
yeah, so the same way, like you said, you like teaching. I also like teaching a lot, and I actually was not happy with the corporate job I did because there was no teaching,
Okay.
apart from other factors. But main factor was there was no teaching, and always had a passion for teaching. So when this academic job came, the vacancy came, I gave the interview straight away, and I got selected. And I was not in like I currently oversee the UG teaching part. So I have 250 MBBS students. We have
Okay.
10 DMLT students. We have some 15 BPMT students and
Mm-hmm.
occupational therapy, physiotherapy students. All their scheduling, lecture schedules, etc. Any kind of internal exam setting, internal marks entry, and all I personally oversee. So I am very much in touch with many of the students because they keep on asking some queries. So why I introduce memes is because I'm very one of the very few faculties who are actually on Twitter. So students
Okay.
feel that Twitter is a very safe place where they can crib and kind of curse the faculties. But yes, I saw Twitter. I use social media a lot, and I saw that students these days are more interested in their attention needs to be grabbed rather
Hmm.
than they giving you attention,
Attention,
because
exactly, sir.
previously students used to focus on the, even if the teacher is not making it interesting, people students used to sit the lecture and sit it out and try to gather whatever information they get. But nowadays students are more practical. They feel that the teacher should grab the attention of theirs, then only they will pay attention to the topic. So one of the methods we use in YouTube videos is to have a hook straight away. Hook means
Exactly,
the
sir.
audience is grabbed
Attention
to
should
that
be hooked. Hmm.
particular topic. So I generally start my lectures with a straight away some kind of humor or a meme per se, especially Marvel memes. Marvel is a favorite, one of
Yeah.
the favorites among the students. So they immediately connect, and those who are sleeping or those who are completing their journals, those who are there on the mobile phone, they immediately start कौन से सर है जो इसे मार्वल बिरवल का
Yeah.
सिखा रहे मार्वल का मीम आई यूज जिफ्स आई यूज मीम
Okay.
फॉर्मेट्स to make a point. Simple example, when I was teaching hypersensitivity, I just used Hulk who was smashing Loki onto the floor in Avengers Towers, and that shows
Hmm.
that when a good thing is exaggerated, your own tissue will be destroyed. Like Tony Stark's whole floor was destroyed by Hulk when he was smashing Loki.
Hmm.
So that
Exactly.
I used for hypersensitivity. Then I used a
Okay.
meme of Hulk punching Thor, and I used that for autoimmunity. Like our own team member is hitting the own body, so I used it for autoimmunity, and so on and so forth. I
Okay.
get ideas looking at going on Twitter and other social media platform, and then I try to put them into my lectures. So students also appreciate it, and they pay more attention and they remember that
Yes, sir.
more. Simple
Okay.
idea, when in my Leishmania
Hmm.
lecture for NNN medium, I had put a photo of Neil, Nitin, Mukesh, so that students remember better, that if they get an MCQ on Leishmania's culture medium, then they will remember sir ne Neil, Nitin,
Anything,
Mukesh
okay.
दिखाया था, so
Exactly.
NNN
Hmm.
medium, triple N medium is the
Okay.
answer for this. So that 1 mark can change their rank by so
Exactly, sir.
many points. So
Yes, sir.
that it does help. And the students, as long as the message is being conveyed, I don't think there is anything wrong in it. The message should be conveyed. It increases retention, but you should not make it too much of that. Yes, the main topic should also be delivered. So I make an attempt that the main content of the disease or that particular infection is also delivered to the students along with the humor side of it.
Great, sir. So, sir, due to as we decided, we are going to have 30-minute meetings. So, the last
Yeah,
question I would like to ask, sir,
sure.
what would be the advice you will give to a emerging doctor like me?
Yeah, so the advice is basically simple. Unfortunately, or practical, because of the practical nature, students nowadays are more focused on what to get as a postgraduate field. I understand to be ambitious is a good thing. You should always be ambitious. I'm not denying that. But some way or the other, do not forget the patients in your quest to become a postgraduate. You
Okay.
have to do the basics right. You have to do your clinical postings right. You, in the end, are going to see patients in the future. Once you pass out, you are going to see patients, and you are not going to be MCQ solving machines. Please
Yes, sir.
understand that. just going and doing MCQs but not doing the postings and just putting it on the faculty that they are not teaching. They just come and read the PPT. Some may be doing it, but it's equivalent to blaming a doctor when your blood sugar level is 300. If the student itself is not putting the efforts, you cannot say कि doctor ही अच्छा नहीं है, मेरा sugar कम नहीं हो रहा है. So somewhere or the other, you are also responsible for your own academic success. So if you are not getting marks, don't say कि ये faculty कुछ भी सवाल पूछते हैं, इसका कुछ use ही नहीं है, वो बराबर से सिखाते ही नहीं है. If you are getting less marks, somewhere or the other, you have to also introspect and you have to realize your own limitations. Not everyone is going to be a cardiologist, not everyone is going to be a neurosurgeon. So you could just look at your peers and say कि मुझे भी neurologist बनना है या मुझे भी super specialist बनना है, इसलिए मैं इतना MCQs करूंगा तो मुझे मिलेगा ही. It's not that way. There is a limitation for each and every one of us. Otherwise, no one would have taken first year subjects, second year subjects as a specialty. There are hardly anyone who will say कि मैं microbiology by choice ले रहा हूँ. Everyone wants to be a surgeon. Everyone wants to be a MD medicine, etc. But that is the truth, that there will always be competition. So keep patients as your focus. Try to learn your clinical stuff more, then solving the MCQs. Learn all the techniques. Like I said, it doesn't matter whether you are preclinical, paraclinical, wherever the time comes, you can contribute in a very significant way towards the society, towards the patient's benefit. Like what we did in COVID, the preclinical subjects also worked very hard. The paraclinical subjects worked very hard in the diagnostics. And obviously the clinicians, so they were facing the brunt of the patients. They got infected much more than what we got. But you have to realize, put the patient at the forefront, keep the patient as a priority, and go blind to your clinics. Don't touch the file when you are going to examine a patient. Then you get the bias. Just on your own, do the inspection, palpation, percussion, auscultation. Do on your own. Let your diagnosis be wrong. Don't say कि मुझे आज CVS का केस देखना है, मुझे आज RS का केस देखना है. Just go to the ward, see any case, do your own provisional diagnosis. The treatment of that particular patient does not depend on you. So even if you make mistake, it is fine. And then see the file and see if you have done a mistake or you are right. हम लोग क्या करते हैं, अरे फाइल में दिखा मर्मर है, फिर हम स्टेथो लगाते हैं, हाँ मर्मर है मर्मर है. अरे you can't appreciate murmur as a second year, third year MBBS students. It's very difficult. So this is something I would want the students to follow.
So you mean, sir, we should focus on clinical stuff rather than theoretical stuff. Okay.
Very much.
So sir, thank you so much for coming to this interview. I highly appreciate it. And I'll hope to see you one day and work with you.
Sure. You can drop by KEM anytime.
Okay, sir. I'll definitely come to you. Thank you so much, sir, once again.
Thank you so much. Have a nice day.
Thank you, sir.